All right, who's all ready? Fluoroquinolone Toxicity Syndrome. I'll go over my background in a little bit, but from a standpoint of treating you and everyone else that I've treated, safe, effective, long-lasting, functionally restorative treatments, regenerative best therapies on the planet is what I'm looking to do. I've been doing my own clinic for about 5 years now, and there's big changes in what I was doing compared to what I am doing now. And I've just very carefully started to show everybody what I'm doing because it's quite a bit more advanced than what's happening in most places in the country. We're developing, creating highly advanced assessments, protocols, care regimens, and imaging. By the way, can everybody see? Somebody unmute for a second. Can you see the PowerPoint?
No, I can't.
I can see it.
No problem.
Yes.
Okay. For who can't, there must be like a share tab or something like that. I shared it with everybody by hitting the share tab. So there should be some option to start the show. Now, when I say this, one person at a time, one life at a time, that's what the clinic has become about. We're only treating 8 to 10 patients a month at this point because of how complex and how deeply we are assessing and treating each person. And what else, if you really want to make me happy, you can bribe me with chocolate. All right, this is what I like to try to show a lot of the other physicians. And this is something that should help everybody feel a little bit more comfortable and confident about what's going to happen in medicine going forward. Things are going to change. They're going to change around outcomes. They're going to change around the fact that physicians and medical systems no longer have a quartered market on knowledge. Knowledge is free now. Using that knowledge effectively and for the good of somebody else is going to start to be demanded. And I'm happy to see that happening. I see most of medicine doing this, and I'm sure some of you are either scowling or chuckling a little bit because shift happens. We're going to talk a little bit about my background and some of my opinions about doing and how to do and who should do regenerative therapies, some of the agents that are out there, how to do assessments, treatments, care, and some things that are going to be coming in the future. I've talked to lots of people about this question. Do I have fluoroquinolone toxicity syndrome? And for those of you who don't know, syndromes are multivaried sets of multi-system signs, symptoms, and dysfunctions happening from either a deep kind of primal sort of dysfunction or multiple dysfunctions. Most of you will know that there's at least 4 different things that we know of that are problematic with regard to fluoroquinolone toxicity. That's collagen destruction, largely due to problems with electron stress and oxidative stress that happens from loss of magnesium and stripping of the tissue, neurologic direct damage, mitochondrial direct damage, and DNA direct damage. That is, by definition, a syndrome. So that's why I call it that. For all those who didn't hear or haven't seen the information sent out there by Jason, after the conference or during the conference, we actually ended up calling ourselves the Fluoroquinolone Antibiotic Advocacy and Healing Alliance, or FAHA. Jason has gone the extra mile of creating a website for the group, and we are beginning to create the multidisciplinary protocols. In fact, on Tuesday, tomorrow night, I'll be getting together with 6 other providers to create a really very upgraded version of what I have been doing for the last few years for people who are coming in from out of town to be treated top to bottom. I love Jason's approach of doing things positively. We're partnering with him on his Facebook page. And I really look at everything from the point of view of healing heart, mind, body, spirit every time. And I offer that to everybody. And honestly, most commonly, most people don't take advantage of all the different possibilities for healing. Like I said, we're going to have 6 different professionals that are going to be out on Jason's Facebook page, helping with questions, advocating, and doing webinars. The one thing we're going to hope to try to do as time goes on is allow there to be a chance for providers who are very versed in fluoroquinolone toxicity to be helping to guide everybody on what to do and how to do it, because the variation in responses to different diets, different supplements, different activity regimens, different regenerative regimens, heart mind healing is very significantly different. And it's confusing to me, honestly, sometimes how to do all these things, which is why I work with 5 other people where they're doing their piece of the equation. And I try to focus mostly on being the coordinator, but also the regenerative expert. All right. Just for what we went over there, probably not a lot of questions yet. So why would we consider adding regenerative therapies? They work. They're minimally invasive, what I call microsurgical, actually, because frankly, what I do is no longer really minimally invasive, and moderately invasive doesn't sound very good. So microsurgical sounds both small and sexy. So that's the word that I use for it. Decreased costs compared to going 20 different directions, or God help us, going to a national group, none of which I will name, and get $70,000 to $100,000 bills for your workup. Faster recovery than just sitting around hoping for something good to happen, or worse yet, starting doing something that ended up being not right for you. We want to maintain and heal your native tissue. That is nerves, that is collagen-based tissue, and eventually that'll hopefully be your DNA as well. Ideally, though, in my opinion, regenerative therapies address the underlying neurologic, psychologic, physiologic reasons for pain and dysfunction, and are going to create overall health and wellness. And when I say the psychologic, I mean the emotional, I mean the energetic, I mean the psychologic reasons that you have challenge. And one thing that you're always going to hear from me is that the challenge that you have right now is that it's just a challenge. Where are you going to let it take you? What are you going to let it become? How are you going to let it serve you in your life? Because just like any other challenge, it'll take you up or it'll take you down. And one of the 3 things that I found that I cannot heal people through is anger, resentment, bitterness. When the heart and mind is in that place, the body can't heal. And that's been the most significant change to what's happened in the last 5 months. I'm sorry, the last 5 weeks since we've been doing a couple of new procedures. Why did I become a regenerative specialist? I started doing this over 12 years ago. It was 2007. Started doing biologic injections with autologous blood. At that time, PRP, the first paper had just come out in 2006, a year earlier, by one of my friends at Stanford. And there was only a handful of us in the country doing this. And as I reflect back on this, and this took me a long time to understand why I jumped into this the way that I did, this fits me. I lived through and grew tremendously from having a chronic illness for 20 years. And the idea of healing from the inside out and the outside in just made a lot of sense to me. And this rung true for me right away. So I started doing these things very early in the game. And ultimately, the goal has always been, how do I become the best healer that I can be? You got to be careful what you ask for, everyone, because I didn't see ahead of time what I was going to become. I'm very happy with what I become, but it's much more complex than anything I ever considered. And I've just kept backing into more and more and more ways to help people to heal physically, mentally, spiritually, emotionally, intellectually. And the more ways that we have and tools that we have, the better that we can serve you. All right. That was my brag line. This is my brag page. I'll let you guys read this. If it's been done, I've done it, and or been the one to help innovate it. There's a small group of about 12 of us around the country who have worked very closely since the beginning, and we've defined and created a lot of what's currently being used out there for regenerative procedures, assessments, and even the tools. Of note, I was there in 2011, 8 years ago, to write the first national guidelines for PRP use, and I've been nationally at about 5 or 6 different cases that I've been an expert witness at for this. There's a whole bunch of things that have happened since then, a whole bunch of things that will keep happening. I like to say that fluoroquinolone toxicity chose me. I didn't choose it. I didn't choose it. I had created paradigms and protocols for all these conditions: Ehlers-Danlos, cervical instability, lumbopelvic instability, freeing and healing nerves in their own fascial planes, fascial plane restoration, arthritis, percutaneous needle tenotomy. Those are procedures to help heal tendons, ligament and tendon injections, so many different types. Peripheral nerve injecting directly into nerves, sciatica, Achilles, incontinence. All of these things have come together in extraordinary complex detail, what I would have never thought of if I was just to sit and consider it myself. All right, so I want to give everybody a chance to be able to say hello and ask a few questions if you want to. About where we've come from, Faha, and my background, why I do fluoroquinolone toxicity. If any of those questions exist, yell them out, please.
So, Dr. Hansen,
Yes.
you find the list that you mentioned right now is coming together in the fluoroquinolone toxicity syndrome?
I found the what?
The list that is showing up right now, the Ehlers-Danlos syndrome, arthritis, etc., etc.
Yeah, so these were paradigms that I created for other conditions that I use as part of fluoroquinolone toxicity treatment.
Ah, yeah, okay.
In other words, what I'm saying is it takes a lot of bricks to build this house.
Uh-huh.
Like just Achilles treatment, and a couple of patients have noticed this in the last few months. There's about 8 different varieties of Achilles dysfunction that I look for, and things that contribute to Achilles dysfunction as part of its treatment. It's one of the most difficult tendons in the body.
Yeah.
And to understand how to work with Achilles is different than working with most of the tendons in the body.
Can you tell us a little bit more about how you assess the damage? Do we need MRIs or other?
Well, we'll get to that. I'm trying to just stick
okay.
to only what I've presented each time. Okay.
Okay, no problem, no problem.
All right, I'll keep going. All right, so here's like a common scenario for what I do for a fluoroquinolone toxicity patient. Those of you who have talked to me know that I'm very big on doing neck evaluations and treatment. Us previously being injured, motor vehicle collisions, falling, sports, working on those nerves and the stability around the cervical spine, restoring posture, affects the whole body more than anything else. The neck is protected more than anything else in the body, so your body will contort completely around your neck, and you might have problems in your low back, your mid back, in your arms, your shoulders, sometimes even in your legs, and you trace it all the way back to the neck. There are actually 4 different types of training within chiropractic that focus only on the upper two segments of the neck. And what we find oftentimes, and this is only after doing many, many years of regenerative therapies, that a lot of people will feel better after doing just a couple of injections in the neck. But if you haven't addressed all of the underlying dysfunctions, a lot of the accommodations and changes in posture and stresses still get pushed out to the rest of the body, even though the neck feels better. So if you have a combination of neck and or other areas in the body that are problematic, I will go to the neck every single time. This is posterior longitudinal ligament, the anterior longitudinal ligament, the supraspinatus, infraspinatus, the capsular ligaments. Capsular ligaments up there, posterior and lateral. Sometimes just in front of the vertebral artery. If you don't have the right skills to do these injections, and you haven't practiced them extensively, you can hurt someone. You could actually cause somebody to have a stroke. So understanding what the problem is only part of the equation. Really understanding how to safely and effectively address it is at least as important, maybe perhaps more important. But these are things from treating upper cervical instability that I've learned over time. TMJs, sternoclavicular joints, that's the one between your breastbone and your collarbone. Then your acromioclavicular joint, that's between your shoulder and your collarbone. The first rib attachments, the rotator cuff. Getting actually all of these neurologic structures together, very common for me. I'll actually discuss later on where I do those, and sometimes IV-based applications. But doing all of these treatments as a group, regionally, where everything is healing together as a regional interdependent group, that thought process actually came from working with Ehlers-Danlos syndrome. That's a condition where people's collagen is very, very weak. These are contortionists. And you might have actually noticed on some of the groups that there are a lot of people that have fluoroquinolone toxicity and Ehlers-Danlos syndrome together. That's a really tough combination, but it was actually working with the Ehlers patients over the years that I developed these regional approaches, and they're very applicable to fluoroquinolone toxicity. There's a problem with them, though. If you put all this together, I'm doing 40 to 60 injections, and these aren't even injections, they're all microsurgical procedures with every single patient, usually spread out over 3 days, 3 different days of injections. But that's what I found with these very complex conditions like fluoroquinolone toxicity, Ehlers-Danlos syndrome, and other conditions. You need to be that complete if you want to give the patient, the person, the best chance to heal. That was from way a long time ago, like 8 years ago. This is my 2 minutes of fame on the doctor's TV show. And ladies, yes, you can go ahead and ask, but I have no idea if Dr. Travis looks really hot because I don't look at people that way. Okay, this is my biased slide. One of the things that I said on my previous slide is I've trained 400 plus physicians how to do these treatments. I've been the director of 25 different conferences over the years, started fellowships, trained physicians for up to 250 days in a full fellowship year. And this is my personal set of requirements for training somebody, and my personal set of requirements for even having a chance at somebody treating me. I'm going to let you guys read these. Again, these are my opinion, but I think they hold water given my experience. So if you don't have an underlying training in musculoskeletal structure, anatomy, or neurologic anatomy, it's very difficult to use fluoroscopic or ultrasound or combination of those imaging modalities to do your treatments. Expert visualization and ultrasound fluoroscopy, arthroscopy, greater than 2 years of experience. I'm sorry guys, but this takes a ton of time to get really good at. It's 12 years for me to accumulate the knowledge that I did, and my first fellow stuck around for another 2 years at the same clinic I was at in Colorado while I was still there, and he's developed into an amazing regenerative doc. Oh, laboratory processing, extremely important. That's an hour-long discussion in and of itself. You got to be able to do your own ultrasounds. There are a lot of individuals out there that will have another individual do their ultrasound, mark spots where they should inject, and then inject. Minimal use of allogeneic agents. These are agents that are not from you. I'm very biased in this direction. We'll go over this a little bit later. Having a multidisciplinary care model, I talked about this at the beginning. It takes a village to heal everybody. I can't do all of the pieces of healing, and neither can any other single physician or treatment or provider. To have all of that knowledge in one skull is impossible. So we have two places that are tracking our outcomes nationally. Many tools in the toolbox. This is many different agents, many different procedures, many different ways of doing things and approaching procedures, not just one size fits all. And then we have an advisory board for the clinic, and I'm forming actually a formal IRB, institutional review board, to oversee what we're doing at the clinic. So it's not just Dr. Hansen's opinion of doing things. It's a group of people that can say, hey, this study says this, and I'm going to let them hold my feet to the fire. There's 8 individuals that are already identified to do this, because I don't want to be the lone wolf saying that I believe things should be done just because that's the way Dr. Hansen likes it. So I don't just try to keep regenerative medicine in check. I have other people that keep me in check. All right, that wasn't a ton of extra information, but we'll stop for a minute and ask if there's anybody who wants to ask any questions about the things that we already went over. Understand that there's going to be a lot that we still have to do, so you guys can unmute yourselves and ask a question if you'd like.
Dr. Hansen.
Yes.
Hi there. This is Elizabeth. I'm out from New York. And my question actually is, given that I'm so far away from you, I want to know, how am I able to screen and choose a provider who may be able to perform these procedures where I am, for instance, or for somebody else who is where they are, as opposed to coming all the way to where you are, because it may be a little inconvenient. How do I screen for the individual who may be providing these procedures for me?
That was that list that I just gave you a little while ago.
So just go through that.
Yeah, just go through that list right there.
Okay.
Thank you. And I will tell you to watch for a couple of things. If somebody has been an orthopedic surgeon or a pain specialist, and they're like, well, I've done this for 20 years or I've done this for 30 years, what I've found is those individuals are the most difficult ones to train in regenerative therapies, because what they tend to want to do is to keep doing what they're doing and just use something different, use a different agent. Regenerative medicine is completely different from pain medicine. There are a few tools that are used similarly, but the mindset, the approach, and the procedures and the agents are completely different. Very difficult to train those people. So when I say 2 years of experience at least, that's doing regenerative therapies only. Okay, thank you, Elizabeth.
Can I ask a question?
Go ahead.
Yeah, so which medical specialties are the easier ones for you to train? In other words, are more likely to be good at this?
Yep, physiatry, that's PM&R. And primary care sports are the 2 big ones.
What about emergency?
Generally, that's very hit and miss, because they don't have a background in musculoskeletal medicine. They have a background in everything. They have a background in, I want to try to save your life. So there's a very broad, deep amount of training in emergency medicine. And truthfully, I mean, there are individuals from lots of different walks of medicine that are superb. They're amazing. But I've tried to train a couple of ER docs, and what I found is their breadth of understanding of the anatomy, physiology, function of the body is not what primary care sports medicine or physiatry is. And then on the other hand, somebody who's done, say, anesthesia, interventional pain, they tend to have, first of all, not very good people skills in general. That's not everybody, of course. They're used to, saying hello to you when they're putting you to sleep and saying good morning to you when you wake up. And they tend to have a kind of a hands-off approach to the person, not very intimate, not very deep, not really understanding all of the different variables that can happen. Don't have a lot of understanding in the deep physiology of why things occur in the body. But they're very good proceduralists. So the biggest synthesis area is physiatry in general, or primary care sports medicine. But I've trained rheumatologists, orthopedic surgeons. I've trained neurosurgeons. I've trained anesthesia, primary care sports, physiatry. I think those are primarily it. I don't train any mid-level providers. I don't train any naturopaths. Again, there's just not the breadth of knowledge. The first guy that I trained in a fellowship for about 250 days in 1 year was primary care sports medicine. So he'd already done a fellowship in sports, had PRP training, had ultrasound guided training. And after 250 days of training him, I asked him how much of what I did he thought he could do. And he was a very humble man, but he said about 40%. And that's 250 days of training. Most of these docs are getting a weekend or two of training and then starting to do regenerative injections. I'm just going to ask you, be careful about that. You want to find somebody who has that matches you, because for every physician out there, there's a patient. I tend to ask for a great deal of collaboration from the patient and a great deal of investment of their time and energy towards healing. And not everybody wants to do that. So you do need to find who fits you the best. So here are the agents that we're going to talk briefly about. This is something that each one of these things I could do an independent talk on. The autologous ones are on the left. That's coming from your body. Bone marrow, there's 3 different fractions of that. Your own blood, platelet-rich plasma, platelet releasates, activated PRP, adipose. There's 4 types of those. 4 types of fractions I get from adipose. Alpha-2 macroglobulin, that's a protein in the body, in the blood. Synovial fluid, vascular aspirates, mitochondrial concentrates, and autologous bone. The allogeneic, or something that comes from outside your body, umbilical, amniotic, exosomes, A-cell growth factors, and chemicals. We're going to talk a little bit about each of these. Prolotherapy, I see this question come up quite a bit on the Facebook groups. Prolotherapy has been around since 1938. That was George Hackett that began injecting different agents into tissue that was deteriorated. So there's over 80 years of experience of this. He taught a guy named Gus Hemwall, who did about 100,000 patients, well documented over about a 45-year career, and using about 8 different agents, and documented really significant improvement in people. Luckily, they didn't have fluoroquinolones back then. Gus died in the early 90s, I think. Studies might surprise you. People do pretty good. Usually it takes 3 to 10 procedures to get there, but outcomes are pretty decent. Relatively less costly, of course, because you're just drawing something up into a vial and injecting it into somebody. So you can do a lot more than the 4, 5, 6 procedures I do a week. Autologous blood, this is the first agent that I started using. Used a lot outside the USA more than in the United States, especially Australia. It's cheap. You're just drawing blood and re-injecting it into somebody, but it hurts like nuts. It's very painful to do. Those red blood cells actually are pretty negative on the response of healing, both in cultures and lab. So in vitro analyses and in vivo as well when we're working with patients. It's painful, and it takes quite a bit more injections, probably similar to prolotherapy actually in its effects. Platelet-rich plasma, my first agent. This is taking blood and fractioning out platelets, and in my case, in my lab, growth factors, proteins, and some stem cells. It's my most common thing that I use. It goes in all of my injections. So when I do a cellular procedure, I'm always doing very advanced platelet-rich plasma with it as well. It is very powerful, easy to get, of course. Hurts quite a bit. When I augment it with different chemicals or with different structures, it can be really painful when it's used. Processing questions abound. So far, the FDA looks like it's going to let this one slide as far as our use of platelet-rich plasma. That'll be decided for sure in 1 year from about today, actually, when the FDA decides what we're going to be able to use and not use. So I've had new fractions created as late as like the last couple of years. I've pretty much figured out, as far as I know anyway, how I can best cannibalize blood to get the best regenerative agents out of it. Who knows? There might be more innovations coming, though. Moderate to high in price. In my clinic, anywhere from $500 to $3,500, depending on how much I'm doing. Let's see. Platelet concentrates and releasates. These are where you take platelets and you're adding something to them to to activate them. So bare collagen will do this. Thrombin will do this. Thrombin is part of our clotting cascade. Actually, you can break open the platelets by freezing the platelets or adding sterile water to them to osmotically break them open. And these are ways that you can get a more pure platelet concentrate of growth factors, usually called platelet lysates or releasates. There are lots of ways to get it done. You can help culture cells. That's what I did for the first 4 years of my career. I was one of the only individuals that stem cell therapies. IRAP was started in Germany. You might know that there's some famous sports players that went and used it. There were 4 centers in the U.S. None exist anymore because the FDA calls certain things that you can do with IRAP, which is essentially taking platelets and using different methods to get them to release certain growth factors. They call that creations of biologic drugs, and that's not allowed anymore. There are moderate studies for IRAP, though. And I tend to use these platelet concentrates together with most of my injections, but especially around nerve structures. Bone marrow, everybody cringes when I talk about bone marrow. I will tell you, though, I've done studies on 100 people 3 times, and 93% in each of those studies said it wasn't that bad to do a bone marrow extraction. But how you do it, where you do it, what angle you do it at, how many places you can access, where you access them, how you draw, tons of questions about how to do it. It actually hurts less than liposuction. Like I said, technique is crucial for maximizing cells and minimizing pain. I'm on my 9th version of how I do it after doing it for the last 10 years. Processing is complex. This too, though, is given a green light right now by the FDA by everything that they've signaled through Centers for Biologics and Ethics Research in the FDA. So hopefully we'll still be able to keep using people's bone marrow. A lot of different progenitor cell types. Mesenchymal stem cell source, although they're fairly low in number, probably 1 in every 10,000 cells. And it's moderate to high in price, usually in the $4,000 to $8,000 range, together with PRP in my clinic. And I typically use these for joints and larger tendon tears, or for individuals that are coming from a distance and I want to treat a large number of areas. I will use it in those circumstances as well as the upper cervical spine is another place that I use this. Adipose fat, that's very confusing. Easy to get to do a little liposuction. Most individuals don't even use guidance when they're doing their liposuctions. Use in processing is controversial. Currently, the FDA considers your fat to be an illegal biologic drug that they get to control through regulation, and I'm not kidding you. There's many ways to process and use it. And yes, some of them are legal, but where you land on that line and how you do things and where you put things is something to be known very, very carefully. This is something I don't mess around with. I was with the clinic that was shaken down by the FDA in 2009 to 2013, and it's not a pretty process, so I keep my nose above water. Moderate to high in price, usually about the same price as bone marrow together with PRP. I use it a lot in same places as I use bone marrow, but certain fractions of adipose are very helpful for nerve use, actually. Alpha-2 macroglobulin, the biggest protein in the blood. This is a little esoteric now, but just in case you've seen it out there, I'll tell you my experience with it. Largest non-immunologic protein in the vascular system, associated with cartilage regeneration. That was done by some docs down in Florida. If somebody's using the official kits from the docs down in Florida, it's about $1,500 just to process alpha-2 macroglobulin. That's a single protein. I bought a $15,000 centrifuge so I can put it in every one of my injections. Moderate to high in price, most places are charging $2,000 to $5,000 just to create this for you. I love this cartoon, by the way. I'm going to rant about amniotic and umbilical stuff later. It's controversial, maybe have some growth factors. A little worried about disease transference, viability. I mean, are these alive cells? Rejection, acceptance, graft versus host disease. It does give you one less procedure because you can just grab something off the shelf and inject it into people. Fairly costly. The places in my area are charging anywhere from $6,000 to $10,000 per treatment. Not much for studies out there. And now we're getting really esoteric. Certain growth factor solutions, fibroblast growth factors, subtypes of these, and bone marrow. Liver concentrates growth factors are also out there. I'm a little concerned about these because bone morphogenic protein, BMP, was actually eventually found, which was used by orthopedic surgeons to help augment bone growth, was actually found to cause lots of problems later on, potentially even some cancers. So I don't know if we want to be using these individual growth factors or not yet. I'm wondering though if things like vascular endothelial growth factor, stem cell factor, platelet-derived growth factor, if these things can be tailored in cocktails and used rather than taking somebody's own blood. Would it be easier, faster, more reproducible? I don't know. That's possible. Pretty expensive. One vial of FGF9 last time I checked was $3,000. Synovial concentrates. This is something I've developed here. We're using it, actually developing it, creating it in that person, drawing it from the person, and using it mostly in joints and in discs. And this is currently being characterized by a cell biologist on what exactly we're able to obtain from people's joints to heal them. My experience with it in the first 9 months of using it is that it causes people end up having quite a bit less pain with procedures. Let's see. And where I'm creating this synovial concentrate, you actually get a stem cell procedure in that location. So it's not an insignificant plus that usually both knee joints get a stem cell procedure in my clinic as part of my more major procedures. Similarly, we've created some mitochondrial concentrates, which extremely important for fluoroquinolone toxicity. And these also are being researched currently. Vascular aspirate concentrate. This is a unique source of stem cells that I honestly happened upon by chance about 7 months ago. Been characterizing the cells with a cell biologist and in research in my own clinic, and we're getting really fantastic numbers. I've got 2 lawyers now that have shown me that I'm within the rules of the FDA to be using these agents. But they'll be actually officially written up in research next year, and they'll be done next year as part of my research. And then there's 3 other agents that we're currently developing here. We innovate, create, research, collaborate, and synergize to be the best healer for you. All right, I'm gonna do 2 slides on the amniotic and umbilical problem that's out in the country. Now, I'm gonna preface this with telling you guys that if I didn't have to prepare people's bodies physiologically, if I didn't have to get their bodies ready on day of procedure, if I didn't have to draw the tissues from their body, if I didn't have to process their tissues, if I didn't have to have the equipment, if I didn't have to have the space, if I didn't have to train the medical assistants, if the medical assistants didn't have to use their time, I would make tons more money than what I currently do. Part of the problem that I have with these agents is they're being sold as the one size fits all and this fixes everything, when there's very little known about them. So I have every reason to want to do this from a financial standpoint, but I do not and I will not use these agents for the following reasons. Not approved by the FDA for current uses, and I believe they're going to be shut down substantially about a year from now. No long or short-term safety studies, no efficacy studies, source handling, storage, transport, generally unknown. The physician or nurse practitioner or PA, whoever might be doing the injections, generally is drawing these out of a vial and they have no idea where it came from. Studies came out actually from 3 different labs this last June, and the viability, i.e. the number of live cells in these agents, almost none. So they run around and do these shows every night in Minnesota, actually, one group, and telling everybody that their own stem cells are weak and they can't heal them. And then they turn around and inject a bunch of dead stem cells into them. It's a sad state of affairs. This has now been covered very broadly on the media, and this is going to partly significantly sink cellular therapies because regulators are probably going to use the experience that people are having with these agents to justify creating really archaic and very, very broadly defined laws to control regenerative medicine. Graft versus host disease, lots of ways to look at this, but basically tissues that you inject into you actually harming your body. I'll let the cell biologist talk about that sometime if I have him on as a guest. You will get immune system reactions. This is actually probably the biggest reason why there's an effect from these. Arthur Kaplan is the father of mesenchymal stem cells. He's been working on them for 35 years. He came out with a study last year that showed that the injection of these cells, umbilical cells, into an IV, they go to your lungs, they get caught in your lungs because these cells are 3 times bigger than the capillaries they're trying to go through. B lymphocytes eat these cells, steal their receptors, and then present those receptors to T cells, which then become T regulatory cells, or they activate T regulatory cells, which can have a myriad of positive effects on the immunologic system for months. So you get a symptomatic improvement because of your immune system without changing the structural damage that's occurred in the body. 12 people landed in the hospital last year after using umbilical cells that were infected with E. coli. And what if somebody's genome has viruses inside that genome already? You can get those viruses from people and they don't even know that they're there. And you can get effects directly on your DNA, either by these viruses or by direct effect of the immune system on your DNA. I'm not a fan of these cells. But these are things that I've been told in 3 different, kind of road shows, sort of coming to our stem cell therapy talks that I've gone to. And here's what they say. Your stem cells are weak. Your stem cells can't heal you. Procedures to get your stem cells are painful. There are no risks using another person's stem cells. These are not my words, by the way. There are no side effects using umbilical stem cells. You don't need any follow-up imaging. You don't need any PT or chiropractic treatment. I've done interventional pain for years. I'm an expert. Here's how I look at this, guys. Your stem cells are not weak, okay? Yes, you might have some DNA adducts, but your stem cells culture just fine. They grow just fine. I've done that before. And I've done this for 10 years with fluoroquinolone toxicity. And yeah, you might have some damage to your tissues, but your cells are not so weak that they can't be used. Just 3 examples for you, and I did these studies. If you change your diet for 1 month, taking wheat and sugar out of it, your stem cells actually double in their function in terms of how well they grow, how well they differentiate. If you optimize your hormones, they triple. If you quit smoking, they quadruple. It's not your stem cells that are weak, it's that your stem cells are being bathed in bad chemistry. That's the problem. But it's easy for lies to be promulgated. All right, now here's just a little humor, okay? There are places popping up all over the place that are doing these kinds of therapies, oftentimes owned by certain types of practitioners, employing nurse practitioners and PAs to do injections. Usually they go to a weekend or two, learn how to do about 12 injections around some kind of guidance, and then start doing quote unquote stem cell therapies. So I call these drive-through stem cell clinics. And here's what you can get at these drive-through stem cell clinics. You can get them if you're dressed in red. You can get them if you're young. You can get them if you're old. You can get them if you wince like a baby. You can get them if you're bald. You can get them with your dog. You can get them if you're a monster. You can get them if you're dead. You can get them on a bus. You can get them if you ignore us. Our staff is very helpful. You can get them if your wife is laughing at you. All right, I had to try to be a little humorous about a subject that frankly annoys the heck out of me. But most of these places are eventually going to go away. All right, that's kind of the roundup on what we use. So for fluoroquinolone toxicity, I'm going to tell you I use very extensively platelet-rich plasma, platelet releasate, platelet lysate, alpha-2 macroglobulin, synovial concentrates, vascular aspirate concentrates, bone marrow, and adipose concentrates, put in very specific areas that are allowed. So with that, there's almost too many details to describe where and how I put what I do, so please don't ask that. But if you have questions about what we're talking about in regenerative medicine, throw them out there now.
Dr. Hanson, Chris Williamson.
Hey, Chris.
We briefly spoke about my asplenic state, and I run high on my platelet count. I have a 2-part question. First part was, somebody with like myself who normally runs between 600 to 700 on their platelet count, would that be actually more beneficial for your treatment, or is that moot? And then the second part of that question is, if you had already had a bone marrow biopsy and had all the flow cytometry and whatnot from that, would that help you to further understand how the patient could heal themselves?
Okay, so on the asplenic state, your spleen normally a spleen sequesters platelets. And Chris, I don't know if we talked about this, but one of the things I do in my preparation with the patients is get the spleen to release a bunch of platelets for me. I usually get about 1/3 more platelets than people do on average in other clinics because I take a couple extra steps to have that happen. I need to make sure you didn't have any conditions in general that messes with platelet function. But if you just stay splenic and you have more platelets because your spleen's not there to hold on to them as a reserve source, should not be problematic. And then if you had a bone marrow biopsy, it completely depends. I mean, if they've gone through flow cytometry and they have some idea of what your nucleated cell count is, that can be helpful. but that's only one of 3 fractions that I use from bone marrow. So for me, it would be, minimally helpful.
Thank you. I appreciate it.
You're welcome. There's a lot to throw at you guys from the regenerative agent standpoint. Each one of those slides is a conference in and of itself on how to use, what to use, where to use it, with what guidance, how to get it, how to process it. It's a lot of very, very complex information. And I can only say to you that I have $150,000 lab and protocols that were created between myself and a cell biologist with 10 years plus of experience using regenerative agents to create some very, very carefully created agents from your body for your healing. I only know a few places around the country that do it at that level of detail. Anyone else on regenerative agents? I should have mentioned, actually, there are places that are culturing cells. I've opened 5 of these places around the world on how to culture and grow stem cells. There are pluses and minuses to culturing. One of the pluses is you get more of them. Some of the minuses are you might get certain subpopulations that grow, more than other populations. There's actually some decreased effectiveness of the cells as they're grown out in culture. So it's not just a numbers game, it's also a quality game. And to do it efficiently and quickly is sometimes juxtaposed in their effects. And then please don't ask me about STEM aid. I don't want to say anything negative. So how do we do this? This is what I call like the basic components of how to assess somebody and how to figure out what you're going to do to treat somebody. But detailed imaging and history and physical examination, this is your assessment. You guys can read all of those things. That's the basics of what needs to be looked at in each individual. And then the procedural skill set, including guidance, procedures, acquiring tissue grafts, processing them. And these are about 50-50 in their effects. If you don't assess somebody correctly, you can't get them better. And if you don't have the skills, even if you know the spots to go to, you don't have the skills to treat those things, you can't get them better either. The problem with medicine in general is we tend to look at things like this when we should be looking at things like this. The process of how things are happening. And this is how I like to explain this just a little better. This is one of the reasons why the pain medicine specialists, the interventional guys, are very difficult to treat. They tend to think about things from the point of view of the primary symptom generator. What hurts? Well, that's a noble thing, but I can tell you it was built on a concept of surgery. They wanted to figure out what was painful, so they do surgery on the right thing. Now, that's a noble idea, and it was an advanced idea 40 years ago when this started. But what about what happens after something's painful? You get neurologic changes, you get loss of stability, motor and dysfunctional tissue overstress, pain where the tissue is degenerating, other neurologic changes. They're like tertiary neurologic changes. You get trigger points, you get pain where tendons and ligaments go into bone. You get pain around the capsules, these highly innervated structures around joints. But before that thing is even hurting, you get abnormal chemistry around that area. You get poor active stabilization, poor passive stabilization. Active is muscle stabilization, passive is ligaments and capsules. There are injuries I would consider fluoroquinolone toxicity in that injury pathway. Neurologic dysfunctions, you'll see this all over my slides. Nerves are extremely important. Hormone depletion, and nutritional problems, genetic problems, and there's more to consider than this. But usually when I put this in front of somebody who's trained traditionally in interventional pain, they have no idea what I'm talking about. Same thing with an orthopedic surgeon. It's not their training. So they tend to have a difficult time with these concepts. So here's my way of complexifying this whole thing, or rather being very, very complete. Fundamental factors of degeneration. These are physiologic dysfunction. That's mostly hormones and immune system. These are your functional providers. Your genetics, and that's often your functional providers as well. Injuries, as we spoke of previously, that's fluoroquinolone toxicity. And many other types of injuries, just physical injuries. There's also deep emotional strain and pain, of which I would imagine all of you can relate to. And then there's neurologic dysfunction. After you get these, you get autonomic dysfunction. This is your sympathetic or fight or flight nervous system trying to protect you. So it restricts the amount of stress, the amount of range of motion, what you can do with your tissue once it's started to elicit a painful response. After that, you get neuromuscular derangement. So your active stabilization, your passive stabilization, your active stabilization change because of your neurologic dysfunction. Then you get accommodating patterns, stress, recruitment, alignment changes. Remember I told you everything contorts around the neck and it's fundamental abnormalities. And then what happens is these things work off of each other. They kind of spin around like a merry-go-round until eventually you start getting secondary neurologic recruitment, alignment, stress, and accommodation patterns far away from the original area. Oftentimes the body's pretty good at taking care of a single area that might be problematic and accommodating for it, but then they start to have problems in a distal area. That's like women who have had children and they end up having some degree of instability in their pelvises. Their hips start to become overstressed, their glutes and their hamstrings don't work very good, and they come in with knee pain. Well, the knee pain is a secondary region. It's not the problem, it's the result of a different problematic area. And having very astute physical therapists and chiropractors to work with me to understand all of these different areas is huge to my practice. Oh, then after that, eventually you finally start to get significant radiologic and symptomatic deterioration, and then these things keep working off of each other circularly. And if you're not dealing with something all the way down into these fundamental factors of deterioration, all you're doing is making somebody feel better. So if I inject, 10 million stem cells into somebody's knee that's arthritic, they're going to feel better because the chemistry is now improved. But it's not going to do anything to the process that caused the knee deterioration. And those things can be extrapolated for every single part of what happens in fluoroquinolone toxicity, and that's a heck of a lot more complex than knee. Just to show you, I don't only think of that, I actually have a similar one that I use with psychologists and with a spiritual intuitive acupuncturist that works in the clinic. And there's similar deeply impacting painful emotional experiences, which then lead to things like PTSD or complex regional pain syndrome. You get coping mechanisms after that. And you get what I call transcendence burdens. That's a Hansenism. Pain, shame, guilt, fear, insecurity, those kinds of things. But nobody sits around and talks about how they're having problems with their coping mechanisms. They sometimes have these deeply impacting, painful emotional events that they talk about. Nobody really knows about this sympathetic layer. But eventually, these things start to work off of each other too. And people start to feel this sense of detachment. And then overt symptoms, finally. They get depressed, anxious, insomnia, sadness, separation, loneliness. This is what they talk about with their overt symptoms. And there's usually no connection to all of these things that are buried deeper. Now, this is one of 5 what I call onions. And these kinds of processes that I'm using deeply with other providers to heal as many aspects of problems for people as we can. Nobody likes to know anybody else to know that they have depression, so they wear masks to cover it up. That's just to let you guys know, you know what, I think about this stuff really, really deeply and really interconnectedly. And I want to tell you this, I want you to heal. I don't want you to feel better. Because healing is going to lead to you being independent, doing what you want to do. And I don't want you to be dependent on me. Neither do any of the other providers I work with. But think of symptoms like this. There's structure, there's alignment, neuromuscular coordination, neurologic, immunologic, hormones, posture, psychologic problems, medication, nutrients, genetics. And you might not get symptoms until like this level. So it's more like this. And if you only treat somebody's symptoms, the best you're going to do is decrease their symptoms for a while. But you have to get down to the fundamental reasons why those symptoms occur to actually have a chance to be able to help somebody heal. This is how I personalize this. There's lots of, I'm sorry, I'm OCD about this, guys. How do I heal somebody? That's all I think about all day. So I think about this in terms of a hierarchy. What order do we do things in? What's their environmental niche like? The chemistry and physiology. How about those alignment and neuromuscular functions? How about their lifestyle? Nice part is this, I had this stuff together before I was working full-time, a lot of my time on fluoroquinolone toxicity. And then there's that neurologic factors. There's 6 different levels of the neurologic system, by the way. And then how bad is their condition structurally? How bad is their defect? That's the healing paradigm. Here's me starting to get into the concept that regenerative medicine is not just poking a needle into somebody and injecting some stuff and saying, hey, I got it in the right spot. My image says I did. Well, what are you doing once you're there? And what tools are you using? Are you freeing those nerves in their fascial planes, what's called nerve hydrodissection? Are you restoring fascial planes that have scars and adhesions in them? Are you actually making micro incisions in their tendons so they heal? Are you making micro incisions in their capsules along the longitudinal aspect of the capsule to get those capsules to regenerate? Are you using bone to graft where you need to? Do you even know how to get the bone to be able to do that? Are you able to inject inside of a nerve safely and effectively? Are you using advanced instrumentation? Lots of them to talk about. I can't list them all. And then, yes, I'm working with a group right now on doing some 3D printing too. So the days of I can get the needle in the right place and do what I'm supposed to do don't exist. The depth and breadth of doing regenerative procedures is tremendous. Here's an example of one of them. This is a nerve hydrodissection. Notice the date up here. This is like 8.5 years ago. So this is the median nerve. This is a carpal tunnel procedure. This is the nerve that gets messed up in your wrist. Here's what it looks like when it's being dissected out of the fascial planes. And guys, I've learned a heck of a lot more since March 4th of 2011. How I treat these nerves and how I unhinge them from the adhesions that exist in their fascial planes. This clip is 1 minute, by the way. It seems longer than that. Watch the precision. Literally using fluid to cut that nerve, the adhesions away from that nerve for it to be able to freely move in its fascial planes. And for every nerve that I find that's abnormal, I do this procedure. All right, this is kind of a long video, but it's I'll show just part of it to you. This is me doing a a neck injection. It's the joint that's between the head and the neck. Very, very, very requires a great deal of precision. It's kind of a long, but I'm showing you how I'm going back and forth between ultrasound and fluoroscopy to do this procedure. You can start to see the needle come from the far upper right there. And I'm going back and forth between looking at the x-ray and looking at the ultrasound, simultaneously guiding these procedures by two different methods. A third of your brain's blood supply on each side is within like a millimeter or two of my needle. It requires amazing precision and amazing patience to do this safely. But a lot of neck instability and pain actually comes from these upper cervical segments. Okay, I'll just show you the fluoroscopy real quick. It gets washed out quite a bit. I'm sorry for that. I'm actually taking looks and seeing exactly where I am. Then I'll go back to ultrasound, then fluoroscopy, then ultrasound, then fluoroscopy. This one, I'm just showing you that if you don't have the guidance skills to do this, this is a C2-3 joint, by the way. So it's your third cervical joint. This circular structure, hopefully you guys can see my pointer. I'm assuming you can. The circular structure, that's the joint. This extension here, this is where there's leakage from the joint. So this joint capsule is torn. And there's now some options for me to be able to try to seal that joint so that it stops hurting from the tears and stops being unstable from the tear. If I didn't have contrast, safe kind of contrast, by the way, this is not gadolinium that I use. And then here's just the DMX results. Digital motion x-ray is an imaging that I use for the neck, actually a live video x-ray showing the instabilities that exist in every different permutation of movement in the neck. I've been doing these for 10 years to plan my neck procedures. So this is 15 months with 3 digital motion x-rays. Here's the gap between the C1 and C2. Is my pointer showing up to you guys?
Yeah.
Yes.
Good, thanks. So there's the gap right there. See how rounded, I'm sorry, how jagged this is, how hard this edge looks? So that edge softened up already within a few months of a treatment, and perhaps even just a little bit less deviation here compared to here. But then a year after that, look how soft this edge is. Look how there's actually a nice little opening there now, and they're nearly perfectly lined up. She went from about 4.5 to 5 millimeters of instability down to about 1 millimeter. This is a lady that had 30 years of neck pain and headaches who now hasn't had a headache for over a year. Not a Floxy. Oh, how do I choose where I inject? Traditionally, like I told you, pain generator, image guided tradition. I started doing kind of a combination of the above, but I decided I wanted to use my guidance to be a sniper, not a scattergun specialist. So, because traditional prolotherapists would use the scattergun sort of technique to inject all over the place, and I didn't like that. Now that I understand a little bit why things are happening, I've added all these pieces into the equation, and I'm kind of a sniper with a big clip on the gun. And there's lots of layers to the onion, like I already said. Now, if you're going to see something that's super unique, this is it. I first showed this at the FAHA conference a month ago, and it's even been redone since then. But if you were to come in, this is what I would do with you. Day 1, I call the energetic emotional day. Call it the heart day. It's 1 to 2 weeks prior to the next procedure. In reality, if you're coming from a distance, usually about 4 or 5 days different beforehand. But we acquire blood, create PRP, and platelet lysate. I do a stellate ganglion block. That's an injection for PTSD that I've been doing for about 8 years, developed by the head doc for the Navy SEALs. And in 80 to 90% of people with PTSD, it like stops their symptoms for 1 to 12 months. And I'm going to say situationally, all of you have PTSD. In fact, all of us have PTSD situationally. If we were put in the wrong set of circumstances, we would act just like we had textbook PTSD. You guys have been through a ton, and working on the emotional and energetic part of the body, very important. Then this highly intuitive acupuncturist actually does acupuncture on you. Then he marks all of the spots where you're energetically kind of stuck. Then I go and inject those with PRP. And then I inject these other areas that I would term toxic chemistry sites. That's a long discussion. And then physical therapy, chiropractic, and deep emotional healing until we get to day number 2, which is the neurologic reset day. This is essentially my protocol for doing complex regional pain syndrome. It's the most painful condition that exists in the human experience. That's not my quote. That's generally accepted as true. I call this the mind day. About 3 days prior to a major procedure. So you acquire blood, bone marrow, and vascular aspirate type 1. I inject the knees and the subcutaneous tissue. 6 different levels of the neurologic system in a specific order, in a specific way to reset the neurologic system. 3 days, usually of physical therapy, chiropractic, emotional healing. There's a fast that I have everybody do in there. Then we get on to day 3, the structural work. Call that the body day. We're using blood, synovial fluid, and vascular aspirate type 2. And then I actually reevaluate you, see how you're doing. Might do some extra ultrasounds on you. Inject the structural components then. Discs, capsules, joints, ligaments, tendons, and fascia. So these major structural high collagen areas that require very specific microsurgical technique and regenerative agents. In other words, like for a disc, I use 3 times the concentration of platelets than I use for a tendon, because that's what that tissue requires to heal. And that's one of 200 factoids that I can give to anybody who really wants to get trained in doing these more advanced techniques. Hey, somebody's got their microphone on. Sounds like you're doing your dishes. Can you turn it off, please? Let's see. And then we do some pain control and some sleep measures, water therapy starting day 3. I've got now a slurry of about 5 different medications that I use that are very helpful at helping the mood and the pain for the first couple of weeks. And of course, continue with physical therapy, chiropractic, and acupuncture. And there'll be other specialists that we bring into this situation if we need to. This regenerative approach is not done anywhere else, especially where we're dealing with heart, mind, body in a coordinated fashion, both regeneratively and with other providers. And that's not to mention this stuff, guys. Fine touch, sixth sense, mastery of guided injections, extensive assessment, the right regenerative agents, optimal processing, heart and mindset healing, body chemistry optimization, playing nice in the sandbox. Physicians are not known for this, I'm sorry. Working with other expert collaborators, careful follow-up, and national tracking. This is all I do. This is all I've done in my career, you guys. I've done stuff with Floxies for 10 years. Oh, and just to underline something that I think is very important, actually. When I say working with expert collaborators, this includes IV infusions. It includes looking at your needs for your cellular health, all the way down to 40 different nutrients that can be measured inside the cells. This is your dietary program based on your immunologic system. This is your hormonal program based on, exacting levels of hormones and how to optimize them. This is, how do you sleep? How do you heal from deep emotional wounds? How do you create a pattern for yourself to be able to move forward meaningfully through your life? There's a lot that I'm not saying, because regenerative therapies mean more than just what I can do with injections and procedures. And that's all offered here. I'm just not underlying that part of it right now. These are the things I found I can't teach other physicians, and this is after being the main trainer for about 400 of them in my career. This is sad to me, but this is rule number one. I can't teach them to intrinsically care about you. Not chase the code, not get the ego plugs, not get the money, not get the book chapter, not to please the boss, not to read out of a book and be told what to do, but to do what you need, why you need it, how you need it. Sad to me that I can't teach that to physicians. If they don't understand that you are their number one concern, they don't get it. Number two, healing is more important than symptom relief. We already went over that. Number three, it takes a village to heal people. Number four, this one's difficult to describe. I would call it being in the zone. When I'm with someone, when I have a needle inside of them, I'm not just looking under guidance. I'm actually feeling in my fingers. What does that tissue feel like? What does it feel like it needs? Where should I go with my needle? How assertive should I be in treating it? Should I treat some adjacent areas? I'm constantly looking for feedback, both intuitively and tactilely, on what to do and how to do it. That takes time. That takes being in the right place mentally and psychologically for me. If I'm not at 100% when I'm supposed to be doing a procedure on somebody, I don't do it until I'm ready. Because if there's something in my way, if there's something, I'm mad about, or somebody cut me off, and I can't be sensitive to what I'm doing in that moment, I don't do the procedure. So here's what's going to get in the way of everything, of this being adopted as the standard of care. Technical skills are complex, equipment and lab costs, working together as a collaborative team. The allopathic world oftentimes has the wrong focus. That's symptom relief, not healing. No insurance. You got these guys who want to tell you how to practice medicine just based on their money or other things that distract from true patient care. Patience is a huge thing, you guys. It's not uncommon for me to be in the procedure room with those 2 second days of procedures for 2+ hours on people. And of course, cost. This only took me 11.5 years to understand. After I do a procedure on somebody, their symptoms are going to get worse for a while. I'm doing more than a surgeon would do on somebody. And eventually they're going to get better, but then they're going to get worse, then they're going to get better, then they're going to get worse. These worst days are when you slept bad, you had a fight with your spouse, you stepped over the dog and hurt your ankle, and the wrong air mass floated in, your low pressure system, and you ate crappy the night before and drank too much wine. Those are these days. And these days are the exact opposite of those things. But ultimately, you're getting this kind of downward trend that's happening through your symptoms. But this is a 6 to 12 month process. Collagen takes 6 months to be formed and to be meaningfully changed into what you need. That's why this is the healing line then. Where these two intersect, I haven't decided what to call that line, but people from here on consistently feel a lot better than before their procedure. But that's 2 to 8 months. If this is done really completely and really individualized and personalized. I'm here to announce in 2020, we're going to have actually, that was a heck of a lot to go through. So I'm going to stop and let you guys ask some questions. Anyone?
Hi, doctor. My name is Mary Ann.
Hey, Marianne.
I'm just curious because I've been on the Floxy site that you're mentioning and Dr. Galili is on. Do you guys do the same thing, or are you treating different parts of the situation with the FQ?
Well, Dr. Galili has a great fund of knowledge of underlying mechanisms. He had to because he had to treat himself.
Right.
So the underlying mechanisms of what happens, and that's what he talked on at the FAHA meeting last month. So the IV treatments and some of the supplementation, we differ on our approach on how we approach those things. I like to do mine with other experts doing the evaluations and treatments. But the subject at hand is regenerative injections, and what we do is quite a bit different. It's very highly personalized approach that I'm talking about and treating, like over a 3-day period of time. That's not anything that's done really anywhere else, including Dr. Galili. And I'm not saying this because I want to make comparisons, but you did ask.
Right. No, 'cause I'm a little confused. I'm in Wisconsin, so obviously you're closer to me than he is. And I was thinking, gee, do I have to go see him first and then I go see you, or can I come directly to you for treatment?
Well, you're gonna really ultimately it's the flavor that you want. I'm going to tell you, I'm very OCD on making sure I'm working with people doing the right things. Yes, doing very deep physiologic analyses, immunologic, hormonal analyses. I let the functional providers, diet and dietitians do that. I know it all well enough to collaborate with them and put it into the right place in the equation, but they do all that stuff.
And they do all that through you, though. I would still be coming to see you. It's not like I'd have to travel to different parts of the country.
Correct. They're all in the Twin Cities.
Okay. So if someone like me was coming from Wisconsin, do we plan on coming out there for weeks at a time, or how does this work?
Well, it depends. We'd only let you in if you're not a Packer fan.
Oh boy. Well, listen, I'm from New York. My husband's a Packer fan, so you'll let me in the door, right?
Okay, I had to stick that in there, So no,
I support because of a happy marriage, but
So it's your option. Generally, I have people here for 2 weeks. Some people have stayed for 4.
okay.
To do more treatments, IV, and/or physical therapy, and/or chiropractic, and/or acupuncturist. My injections are typically done, like, say, on day 1, day 5, and day 8. And that in-between time is spent with the other providers. So
Okay.
you can get a very, very well-rounded program in 2 weeks. If you want to come back and forth, you can do that too. The only thing I don't like about that is the reason I like to have everybody see physical therapy, chiropractic, and acupuncture, as well as functional medicine, is it's hard to reproduce these individuals. You guys will see their videos pretty soon. We're just getting them edited for Jason's Facebook site, and you'll get to see the level of integrity and level of interest these individuals have. Their expertise is very, very hard to match. So I like you to get the good flavor of what it's like to work with somebody who's very focused and very individualized and personalized, and then they can help your providers do a better job.
Okay.
So
it would be good to plan on coming out for at least a couple of weeks, maybe even 4, and then I'm assuming we stay in hotels. We have family in the area, or do you have a facility that people stay at?
We do not have a facility, but we're right next to the Minneapolis-St. Paul Airport, so there's dozens of hotels.
Okay, well, great. We have family out that way, so that's a lot easier for us than going to California. That's why I'm asking. I was a little confused. I thought first you see Dr. Galili and then you go see you, but it sounds like you're working on the entire thing, not just part of the toxicity issue. You're working on everything.
Yeah, and we are, and Oh, I'm a synergist by nature, Marianne. I like to work with people. I like to teach people. I like to share knowledge. So I did offer that to everybody that came to the conferences. Let's make some standards for each
Yeah.
of 6 different areas for treating fluoroquinolone toxicity, and let's create a system where there can be a dozen places around the country so that people don't have to travel to here or to California or wherever. I mean, there are always going to be people who want to come and see me because I'm the mad scientist who created a lot of the injections, and that's fine. But I'm also happy to train people to do this. I have 40 different conditions that I treat, and like I said, I didn't choose fluoroquinolone toxicity; it chose me.
Okay, good. Thank you. Appreciate the answer.
You're welcome. And let's see. I suppose on one of these slides, I should have had some clinic contact information, shouldn't I have?
I was going to say, I hope you're going to include how we get a hold of your clinic and.
I will do that at the end.
Okay, great. Thank you.
You're welcome. Here's what I'm doing in 2020. I will be doing 7 studies, each with 20 different participants. Fluoroquinolone toxicity will be one of those groups. So I'll probably only be treating 20 fluoroquinolone toxicity patients next year. Because at doing, like 10 patients a month, because I need that much time to really carefully focus on people, I can only do, about that many of each condition. This one I'm being very inspired to do. Each of these conditions need the information out there in the literature on how to do them very high quality and very, very complexly. And what I'm doing and how I'm doing it's not represented in the literature. So I need to get what I'm doing out there.
Right.
So next year looking at just 20 or so floxies that I'll be working with. If there's for some reason that there's not other things that are filling up, I'll do extra ones, but kind of anticipating that once I start letting everybody look under the skirt a little bit with what I'm doing, it's going to fill up quite a bit, quite fast. I've not done any marketing yet
Okay.
in my 5 years of existence. In fact, I didn't have a website until about 6 months ago.
So if I go through that phone number that's the stem cells and that you have on Facebook, there's a phone number listed there. If I call that number, then I should be able to get in to see you, hopefully.
Yeah, and Angie is the coordinator for everything.
Okay. All right. Thank you.
You're welcome. That's my procedure room. The most important thing about the procedure room is this really cool speaker up here. You get to listen to whatever music you want to during the procedures.
I was going to say, there's got to be music or something coming in there.
It relaxes you.
Okay, great.
I do spa music mostly, but some people are like, I want to listen to some Led Zeppelin. I'm like, okay.
We'll discuss music.
I forbid ABBA.
No, ABBA? Okay. I'm more of an alternative kind of a person, I guess.
Okay. What other questions do we have?
Dr. Hansen,
Yes, ma'am.
I can see that this would really work for people who have tendinopathy problems, but I'm not sure how it works for people who have mostly neuropathy.
So that slide that I did, that was the 3 different days.
Yeah.
So the second day is all neurologic.
Okay.
So I'm doing the central nervous system. I get there 2 different ways. The sympathetic nervous system, that's the fight or flight nervous system.
Mm-hmm.
We do the nerve roots. So from the spinal cord as they're coming out into the body. The compound nerves, that's like the sciatic nerve or the brachial plexus. The individual peripheral nerves that are affected, and that's doing the dissection procedures and or inside the nerve injections. That's entirely guided by ultrasound, and where the nerves are abnormal is exactly where we inject them. And then the superficial peripheral sensory nerves, that's called neuroprolotherapy. So it's a 6-step neurologic reset of the body all at the same time. And the neurologic system is kind of like oh heck, I'm sure there's a good analogy for it, but when you touch one spot, it affects the whole neurologic system. And the dysfunctions that happen in the neurologic system, like sympathetic dysfunction, complex regional pain syndrome, centralized nerve problems, usually are existing at multiple different levels at all the same time. So this hard reset of the neurologic system is why I do day number 2. What I did for complex regional pain syndrome fit really well with what was happening with fluoroquinolone toxicity. That's why I listed it as one of those, like janitors to my fluoroquinolone protocols.
What tests do you like to see before you actually see the patient? What kind of medical background records, those kinds of things, do you like to see before you decide a patient is somebody that you would be able to work with?
Usually there's some imaging. So I'm biased on imaging. So for the neck, I only do digital motion x-rays. For peripheral tissues, I do the diagnostic ultrasounds myself. Been doing those for 12 years. But for backs, we need MRIs. And here's the common sort of scenario. You saw the one slide where I was talking about doing the neck and then kind of everything in the upper girdle of the body. So shoulders, elbows, wrists. You do all those things together, but generally I don't mix that with anything below the belly button. So if you have a ton of stuff going on in your neck and out to your arms and in your back and down into your legs, I'm almost always going to suggest that you do your neck and everything associated with that first, and then see what that does to the lower extremities. Generally, EMGs are not necessary and biopsies are not necessary. Neurologic examination will show those to me, and your symptoms will tell us that. And typically that small fiber neuropathy problem can usually be worked on between acupuncture, neuroprolotherapy, and direct neurologic injections into the nerves.
Okay.
The other neuropathies where there's not, small fiber and it's just kind of generalized neuropathy, here's the other 4 levels of the neurologic symptoms: the compound nerves, the sympathetic nerves, the nerve roots, and the central nervous system. And those things generally need to be done in tandem.
Dr. Hansen, do you think that there are still fluoroquinolines in people's bodies?
Probably. Hard to get, especially even just the fluoride ion. I mean, hard to get that out of people's bodies. There's some thought on how to do that, and it's a little bit how to get the fluoride out. There's some thoughts on how to do that. That'd be a one way, which is the fluoride ion itself. The other way is, according to the research that was put forward by the Fluoroquinolone Research Group. I gave that presentation at FAHA because the 3 individuals that created the study couldn't be there. The fluoroquinolones can morph and chemically attach to guanine in the DNA of either the mitochondrial or your cellular DNA. So that's the other way that it can be sequestered in the body. And I'm entirely leaving it up to that group to tell me when they think there's going to be some options to be able to try to, for lack of a better word, cleanse the DNA. There's a paper from 2017 that I pointed out at the FAHA conference that Jersey said it was okay for me to do, but I don't want to steal his thunder. He's done some amazing things for everyone. And
Right.
let's just say that he had some ideas, and they're not ready to be released yet, but stay on the edge of your seat.
Thank you.
You're welcome. Okay. Is everybody a member of?
Dr. Hansel, I have a question.
Yes.
I know you get to see a lot of FQ patients that are differently affected, right, with different kind of problems. But can you do an estimate of the average cost a patient would make?
So for all 3 days of doing procedures, and let's see, that's 7 different regenerative tissues that we're harvesting from you. Usually about 5 hours in the procedure room total. It's somewhere between 10 and 12,000 for the regenerative injection piece of it.
Okay. Thank you.
You're welcome. Oh, the complexity of treating this is really very humbling. And I am looking forward actually over the next few years getting better and better at which agents, where, how concentrated, with what combinations. There's going to be probably endless varieties, and then being able to apply them to each individual in a way that's going to be meaningful while we're trying to stop the entire underlying process. It's very complicated, and for whatever reason, I must be just masochistic enough. I really like complicated things. But partly, and thank you for nobody for bringing up things about the FDA and providers and pharmaceutical companies. As I put out there before, FAHA's objective is to heal people, and something's happened and something terribly wrong has happened. But we're never, if we focus on the wrongness of something that's happened, we can't heal. So that's why I don't do a lot from the side of trying to get the FDA to change things. And I'm most interested in catching things as early as possible, trying to get providers to stop prescribing. I actually did a TV interview about 8 years ago in Denver. You can find it out there somewhere. It was on Channel 7 on the use of these antibiotics. I'm trying to curtail their use. Oh, I would just rather treat individuals than try to fight the state. So thank you everyone for keeping everything positive and information centered tonight so far. I'm still available if you guys want to ask more questions.
I do have one more question, Dr. Hansen. It's Elizabeth again. I've noticed myself that my body reacts to various, let's say, medications or food or other things that I would put into my body that I feel is maybe the way that I process it is a little bit different compared to what it was like prior to floxing. So my question then is regarding the not necessarily the techniques, but whatever you are injecting into the patient, and I'm not sure if you're using lidocaine as well, but in addition to that, for instance, my pain threshold is ridiculous. Now, anything that touches me that wouldn't have caused me pain causes me pain now. So have you noticed people's floxing like worsening severely due to whatever it is that they get injected in per se, in that respect?
Good question. And that hyperesthesia thing is really difficult. It's almost like the hyperacusis sort of thing. There's some things that are just really challenging. Now, number one, I only use ropivacaine. It is the most expensive anesthetic that exists, but it's also the least toxic one.
Mm-hmm.
Call it white lightning. Super expensive, but very effective. And so far, I haven't had any floxies react to it that I know of. I do have a few patients that, most of them that just didn't respond, more than got worse. There are a lot of people in process, of course, and I call it in process being like 6 to 18 months, because nerve stuff can change for 18 months easily. where most of the people will have slow improvements over the first 6 to 12 months, and they tend to peak around that time. But in general, it's more that somebody's not getting better, and this isn't entirely the case, but a lot of times that happens where the heart, the mind wasn't ready to heal. And I probably at that time should have been telling people, listen, you need to go home and you need to heal psychologically before I can heal you physically. But there are some people, there are just a few patients that haven't gotten better at all. And those are the ones that keep me up at night. Those are the ones that help me figure out next things to do, to be more broad, more deep, more careful, more complete in my assessments. So I tend to hound those people a lot. Did you do this? Did you do this? Did you do this? I guess what I see more commonly, Elizabeth, is that there's, I'll get like whatever parts of the body I tend to work on, they get better, but other parts might get worse, which might just be a relative thing. But the most common scenario for that is if somebody's got neck and pelvis stuff going on at the same time. I found that's just too much for the body to understand and to meaningfully neurologically integrate through all of those areas at the same time. And I'll usually, like I said, get people to go towards neck because there's a much better chance of the neck helping to improve the pelvis than the other way around. And sometimes, if somebody's a lot more symptomatic in the pelvis, we will do that first. But then I've had people that get a lot worse in the neck. So it's this balancing act that can be very difficult. And I try to have somewhere between 4 and 8 months in between treatments because it just takes the body that long to heal before I do another area. I will do as much as I can do that's likely to be beneficial for somebody. And whether I do like 20 spots or whether I do 60 spots, I don't charge anybody. I don't charge people any different.
Thank you.
You're welcome. I'm going to tell you from my perspective, everybody, and I didn't do this intentionally. I didn't learn this intentionally. I backed into this. The number one thing that is going to help you to heal is to choose that you are going to do whatever it takes to heal. To have that mindset of my body is not broken. It's struggling, but it's not broken. It can heal. I'm going to allow it to heal. I'm going to mentally, psychologically commit myself to that. And it's not uncommon that I get things thrown at me for saying this, but I'm going to tell you my perspective of the world is nothing bad has ever happened to you. You might have struggles, you might have challenges, you might have difficulties. Things might be very painful and very hard to modulate. That doesn't make them bad. That just makes them a significant challenge in your life. And those challenges ultimately can make you better. They'll just take you in a different direction. They'll make you stop being what you were. That hurts and that's hard. But if you accept this as something in your life that can make you a better version of yourself and flow with it, it'll be the best potential journey that you can have with it. Because if you're angry at it and you fight it and you try to make it your enemy, you're only fighting against yourself and you will trip yourself up. Now, I didn't have fluoroquinolone toxicity, but I did have a seizure condition for 20 years. And a lot of that perspective is born out of having that condition myself. So what I say to people is choose to heal. You don't have anything to fight. You're going to have a lot to learn. You're going to learn yourself. You're going to learn your body. You're going to learn your physiology. You're going to learn your mind and heart at different levels than what you ever have experienced in your whole life. And you can make it a truly amazing journey. I wish I would have done that. My first 16 years was me trying to fight having seizures. It was only the last 4 that I accepted them and figured that I would use them as a plus in my life. And I hope that you guys can leave things in the past, look forward, choose to take this as a challenge that's going to take you into a new part of being the new you, perhaps even the truest version of yourself that you've ever known. I know that's kind of heavy philosophy for one of these kind of seminars or webinars, but it's the most effective way to get yourself on the healing pathway. I'm sorry, I think I just cut off Elizabeth again.
I was saying that absolutely, it's pretty deep, but I tell you that I'm listening to you and it is so good. You're doing such a great job with helping me to heal even just by listening to you.
Thank you. And you know what? I put this out there today to Jason. Jason's done a tremendous job at being the example. Everybody has that anger. I mean, just that vicious anger that something could be introduced into their life like this from somebody they trusted, and the amount of the amount of distrust that exists in the medical system from your guys' point of view is absolutely valid. I know I'm fighting an uphill battle. I'm an MD, and that's probably who harmed you. Inadvertently, of course, but that's where it came from. So for someone like Jason to get through as far as he has, to use as many different things to learn himself like he has, and then to take this as a way for him to become something new in his life is breathtaking. It's awe-inspiring. It's my story that I had from having seizures, but he's a Floxy. And that holds so much more weight. I can blab all day about how I recovered from my own chronic illness, but it's not your chronic illness. So I'm super thankful to have an example out there for you guys. And yes, Jason, you can give me the raspberries for mentioning you.
Dr. Hanson, Chris Williamson again. I have another question for you.
What's up, Chris?
So, obviously we all have garnished that you have a great deal of expertise, especially with Floxies and whatnot. And so with that and with that data set that you have, what would you say is the difference in recovery between somebody who's been floxed for 6 to 18 months versus somebody who's been floxed for greater than 5 years?
I'm going to say add a month for each year.
So add a month of recovery time for each year over 1 or over 5?
No, for each year of being floxed, add a month. The recoveries tend to happen quite a bit faster if somebody's catching it in the first year and treating it as quickly as possible. But I think my furthest out is 22 years at this point. And generally, I'm getting people 50+% improvement. And that's mostly with the regenerative injection side of it. It's not doing the much more elaborate, coordinated approach.
And would you say 50% is plus or minus about what's maximizable? Or, I mean, obviously you could keep trying to go for 100%, but there's a point of diminishing return as well.
Yeah, generally I'd say, I'm conservative on the side of doing more procedures, unless we had to split the body in half and we knew we had to do two procedures. I tend to be conservative in redoing procedures until there's there's no gas less left in the engine, and there's no improvement that's continuing to happen. I will usually say, all right, you know what, let's wait as long as we can. But if we do decide to do a second procedure on the same areas, usually you can expect about half of whatever you got the first time.
Thank you. I appreciate it.
You're welcome. All right, who else out there's got questions? All right, so because I forgot to put it on the presentation, the phone number to call for the clinic is 612-800-5096. And I will do like a 15-minute phone call with you if you want to. If you're sure you want to come, then you just and any of my staff can do that. But if you're sure you want to come, just ask for Angie. She'll set up all the pieces and parts of the equation. All right, you guys, if you don't have any other questions, I'm going to say thank you.
Thank you.
Glad to have the opportunity to chat with everybody. I think it's been about a year since I did a webinar. By the way, I'm just going to tell you, I'm going to let you look under the skirt a little bit. Since we've been doing the combined 3 procedure approach, 7 out of 7 people have had almost the best outcomes that I've ever seen before. I hate to make too great of expectations, but I just texted everybody who's in my regenerative group around the Twin Cities. That's about 15 providers that I'm teaching or training or working with. And just thanked them. I said, you know what, we're creating change here that I couldn't have ever expected. I have yet to test that on fluoroquinolone toxicity patient. So, and I know I got a couple scheduled next month. So I am excited to see what this new set of protocols is doing with fluoroquinolone toxicity. I'm always available if you guys need someone to chat with, and I'll probably do this once a month, and I'll probably pick subsections from here on out where we're doing stuff more on tendons and ligaments, certain areas of the body, or just nerves or the brain, where it's not quite as elaborate. Give you guys a little bit more time to be able to ask questions. Tomorrow night, I also will be asking everybody that's in my fluoroquinolone regenerative group to be doing a webinar once a month as well. So that'll be functional medicine, dietary, physical therapy, chiropractic, and energetic/emotional healing. As well as be out on Jason's Facebook group to answer questions sporadically, at least a couple a week each, to try to add to the equation people who have some medical expertise in working with floxies. Any other ideas on how we can best serve you guys?
Yeah, get insurance to cover it.
That's a very common sentiment, but I'll be honest with you, they'll never cover what I do.
Yeah, it is.
2,
very
3,
sad.
4 injections at a time. They'll never cover, 20, 30, 40, 80 injections all at once. But it's a good point, because even if it's out there, there may be able to be, some compensation that you can get by, submitting it to your insurance company.
There's so many people that need this kind of help and they won't ever be able to get it because they can't afford it.
Yeah, it'd be nice, actually. We'll have to. It was an idea that was kicked around through FAHA, actually, to use try to do some kind of fundraising, and then try to attract clinics around the country who want to learn each of the 6 areas of healing. So those things are on our minds. Of course, first you need a code through the AMA before that any of that can happen. So
Yeah.
And I'm not kidding. I do know 2 individuals that have had more than $80,000 in medical bills just from the workup. I like, you know, national centers, very well-known national centers, which I shall not name, who looked at them at the end of it and said the same thing. Well, it's probably from that fluoroquinolone, but we don't have a code for that, so we can't diagnose you with it.
Would that,
Yet
be
they
one,
prescribe
would
it.
that be one of the major facilities in your geographic area, doctor?
Do I have any in my?
No, I said, would that be one of those major facilities in your geographic area?
I shall not say. They shall be left unmentioned. Oh, but it's otherwise known as a condiment.
Yes, yes. I've spent some time at the condiment in a couple different cities.
They do what they do well. I actually have them to thank for taking out my brain tumor and not having any seizures for 17 years. So I can't complain about them too badly. All right, you guys. I look forward to helping out as many as I possibly can. Stay tuned for everybody that's going to be coming forward with their own piece of the equation.
Thank you. Appreciate your time.
My pleasure. You guys take care.
Thank you, Dr.